Welcome again to our Ground Round series. Have a few housekeeping announcements to make before we get started. Firstly, there's no commercial support for this program today, and any financial relationships of the planners or speakers have been mitigated. If you have questions for the presenter, please wait until the Q&A segment. And if you are viewing online, you may post questions in the Q&A, and we'll read it aloud when time permits. It's my pleasure today to introduce our Ground Round speaker, Dr. Christine Sykalo. She's a cardiology fellow here at Northeast Georgia Medical Center and one of our chief fellows. And her career interests are in the area of general cardiology, and she plans to remain in Georgia once she completes her training just in a few months. She initially came here as an internist and resident, and she was one of the first classes, so she's really stayed here throughout most of her training. Her clinical interests are in the areas of preventative cardiology and women's cardiovascular health, with a particular focus on sex-specific risk factors across lifespan. She's passionate about improving recognition, risk stratification, and long-term outcomes for women with cardiovascular disease. Want to take this opportunity to welcome her and have this discussion about women's heart health. Thank you.
Hey everyone, good morning. I'm Christine Sykalo, as Dr. Eckelum said. And today I want to talk about women's health. I think you all attended the grand rounds that Dr. Taliva did earlier in the year on Inoka and Minoka, so we're going to skip that topic and focus more on the pregnancy complications, outcomes, and life after pregnancy, the postmenopausal period, as well as menopause. I have no disclosures. So the learning objectives for today are going to be identifying blood pressure targets, treatment, and complications in pregnancy, recognizing pre-eclampsia and peripartum cardiomyopathy, and applying practical preventative strategies. So why this matters is cardiovascular disease is the #1 cause of death in women in the United States, and it is still underdiagnosed and undertreated. There is a persistent outcome gap. And if you look at studies from 1984 until 2012, more women died of cardiovascular disease every single year in comparison with men. There was very limited awareness on sex-specific research regarding mortality and outcomes in women, and the heart centers for women began opening in the year 2012. After that, moving forward to 2014, 2015, that was the first time in the history of this country where death rates in women were comparable or below that of men with cardiovascular disease. I'm really glad to be presenting in February because it is Black History Month and American Heart Month, so I think it's a great time to talk about this, and March is Women's History Month. So gentlemen, remember that International Women's Day is March 8th. Don't forget the flowers. But let's actually focus on the framework for this talk. So we're going to start with pregnancy, and then, as I mentioned, go through the rest of life. In women, risk factors, some of them are traditional and obviously very similar to men, and some are very different. So things like diabetes can increase relative risk for heart disease and complications, which is a universal issue. Hypertension can lead to heart failure with preserved ejection fraction, which is seen in obviously both men and women, and then smoking is still our greatest risk factor for myocardial infarction. However, in females, there are additional risk factors such as pregnancy, menopause, complications of pregnancy, adverse outcomes, PCOS, other hormonal imbalances, and cancer therapy, specifically breast cancer and the associated drugs with that. So pregnancy is a stress test on its own. It reveals endothelial dysfunction, and it's a great predictor for ASCVD and heart failure risks in the future. Normal pregnancy requires major vascular adaptation, and it leads to increased plasma volume, decreased systemic vascular resistance, and increased nitric oxide-mediated vasodilation and healthy placentation. Adverse pregnancy outcomes, especially those related to pre-eclampsia or hypertensive disease of pregnancy, are very important disorders and typically associated with issues of placentation and maternal endothelial dysfunction. They often unmask previous pre-existing cardiometabolic vascular vulnerabilities and basically just get shown during that stressful period in pregnancy. So one of the most important topics to cover, and we're going to spend some time on this, is blood pressure and pregnancy, because there's a lot of different guidelines. Some of them disagree on the numbers and the actions that, as clinicians, we should be taking. I do want to draw your attention to the blood pressure goals because they are different in pregnant and non-pregnant patients at this point in time. So by definition, chronic hypertension is defined as high blood pressure that's diagnosed before pregnancy or up to 20 weeks during pregnancy. Gestational hypertension, however, is high blood pressure that develops after 20 weeks of pregnancy. Pre-eclampsia is high blood pressure during pregnancy with additional health issues during that time period and protein in urine, which we're going to discuss a little bit later. And then eclampsia is a severe complication of pre-eclampsia that's associated with seizures. And then finally, HELLP syndrome becomes a medical emergency. It's life-threatening. It's an issue of hemolysis, elevated liver enzymes, and elevated drop in platelet count. So the CHAP trial looked at chronic hypertension in pregnancy, and is actually a very recent study that was released in 2023, and the secondary review was done in 2025. So this was an open-labeled, multicentral, randomized trial with 2,400 women enrolled at a gestational age under 23 weeks. The CHAP trial demonstrated that using a blood pressure target of 140 over 90 millimeters of mercury to initiate or titrate therapy reduced adverse pregnancy outcomes without compromising fetal growth. If you look at any of the trials that were done in pregnancy, that was one of the biggest risks, that if we draw blood pressure too low, that there's going to be issues with placentation and hypoperfusion to the fetus. So after the study came out, the American Diabetes Association actually now recommends a target blood pressure of under 140 over 90 for pregnant individuals with diabetes and chronic hypertension. Secondary analysis of the CHAP trial that came out just recently in 2025 showed that pregnant women with diabetes who achieved blood pressure under 130 over 80 had significantly lower rates of preeclampsia with severe features and preterm birth. The primary outcome of the composite trial was preeclampsia with severe features, medically indicated preterm birth at less than 35 weeks gestation, which we'll cover in a little bit here, placental abruption, or fetal or neonatal death. So as of today, the blood pressure guidelines in pregnancy are published by actually several different organizations, and they still differ a little bit, but the general gist is that goal of 140 over 90. The American Heart Association and the American College of Obstetricians and Gynecologists recommend maintaining a blood pressure between 120 to 160 systolic and 80 to 105 diastolic in pregnant women requiring antihypertensive therapy, again, with just a great concern of dropping blood pressure too low. However, women with severe hypertension of greater than 160 over 110 should always be treated to reduce maternal risk, including stroke, pulmonary edema, and placental abruption. If you look at international guidelines, however, in Europe, they have a lower target than we do in the States of 110 to 140 over a diastolic in the 80s, rather than going up to the 90s or even hundreds as we do here. And as I already mentioned, if blood pressure even once drops below 90 over 60, recommendation is to cut back on antihypertensive therapy. So for all the clinicians in the room, just a friendly reminder of the importance of choosing medications in women who are of childbearing age. So I like the mnemonic, hypertensive moms love nifedipine. It's just a great way for me to remember which medications actually are approved during pregnancy. A lot of times as clinicians, we tend to choose an ACE inhibitor or ARB for most of our patients. However, again, if you have somebody of childbearing age, the potential of becoming pregnant, please avoid those medications because they are teratogenic in that initial pregnancy period. Hydralazine oral can be used, although it's not as well studied as some of the other medications, and it is more used as an IV medication in hypertensive emergency and to lower blood pressure acutely. Methyl-dopa is one of the best studied, oldest medications that we have to be used in pregnancy. But as of right now, labetalol and nifedipine are actually the front runners. They work very efficiently, they're fast, they're easy to obtain, much easier to titrate. So those tend to be our first go-to drugs. So let's talk a little bit about pre-eclampsia, what it is, and things to watch out for. So in pre-eclampsia, it's a systemic vascular disorder characterized by new onset hypertension and proteinuria after 20 weeks gestation. Again, just because if we're before that 20-week period, it's considered a complication of chronic hypertension rather than pre-eclampsia. This is the leading cause of maternal and perinatal morbidity and mortality. Things to watch out for are severe features of pre-eclampsia, which do change your management a little bit. It's that blood pressure over 160, greater than 160 over 110, that maintains for at least 15 minutes without improvement. Neurogenic symptoms, so severe headache, visual changes, seizures, pulmonary edema, elevated liver enzymes greater than 2 times the upper limit of normal, severe right upper quadrant pain, platelets below 100,000, and then creatinine greater than 1.1 or doubling compared to whatever their baseline was. The pathophysiology for preeclampsia is believed to be maternal endothelial dysfunction caused by placental antigenic factors and vasoconstriction, reducing nitric oxide and increasing oxidative stress. This isn't just an issue of blood pressure going up during pregnancy, it's a systemic vascular disorder. And the reason it's so important to ask about has the woman ever had this before, has anyone in her family experienced preeclampsia, is because there's an increased risk of developing hypertension, chronic kidney disease, heart failure, and CAD later on in life, because again, this is one of your initial markers. So there's been some meta-analysis done on preeclampsia and random effect analysis. There were 22 studies that were identified with a total of over 6.4 million women and about 260,000 of these who had preeclampsia. The study showed a 4-fold increase in future heart failure and 2-fold increase in risk of CAD, stroke, and death because of coronary heart or cardiovascular disease. So again, the recommendation is lifelong monitoring, and as clinicians, one of the most important things for us to ask, which honestly, I don't do most of the time, but I should, is any woman, just ask them, have you been pregnant? Did you have any issues during your pregnancy? Because for us, this can be a red flag to indicate closer monitoring. So I just wanted to touch briefly on the approaches to preeclampsia from a physician standpoint. Your really main treatment goals are to prevent maternal stroke and seizure, stabilize the blood pressure, not normalize it. We're not trying to drop it abruptly. We're just trying to get it to a safer level. So get them below that 160 systolic mark, prevent eclampsia, which again comes with seizures, deliver at the right time, and then manage postpartum risks. Women who do have preeclampsia with severe features, especially anyone who's had eclampsia or a seizure, do receive magnesium sulfate. Important to know that magnesium does not lower blood pressure, but rather it helps prevent seizure with cerebral vasodilation and NMDA receptor antagonism. So that's the reason that we use it. I put in the doses just for all our clinicians in the room, if you guys want these slides later to have it as a reference point. And one of the more important points is when we give magnesium, a lot of times it's an infusion that's ongoing for hours, sometimes days, and we do have to keep rechecking magnesium level, but more importantly, watching for early signs of toxicity. So loss of reflexes, respiratory depression, cardiac arrest can all be complications of too high of a dose of magnesium. So if we see this, please, again, as early as possible, stop the infusion, administer calcium gluconate. So the definitive treatment in preeclampsia is delivery, which does bring up an interesting point of there can be preeclampsia in the postpartum period as well, which is one of the diagnoses that is most often missed because in our mind, we delivered the baby, the issue is gone, everything should go back to normal. And unfortunately, there are rare cases where preeclampsia can persist for up to 6 weeks post-delivery. But in general, the recommendation is if the gestational age is above 37 weeks, regardless of if we got the patient stabilized, is just to go ahead and deliver. If we're under 34 weeks, then the discussion becomes of risk and benefit to the fetus and the mother, and to administer corticosteroids if possible and if the patient has been stabilized. Obviously, if the patient is unstable, regardless of gestational age, the recommendation is for delivery. One topic I wanted to talk about, because I think especially with everyone being cardiac in the room, we administer aspirin on a daily basis to patients with CAD, and nobody really thinks about giving aspirin to a pregnant woman. But there are guidelines from the American College of Obstetrician and Gynecologists, the USPF Preventative Force have a grade B recommendation, and the Society for Maternal Fetal Medicine also recommend administration of aspirin in specific cases. Aspirin has been shown to reduce the risk of preeclampsia, especially early onset and severe disease. It acts via platelet inhibition, improving placentation and those endothelial effects, and typically low dose tends to be very well tolerated, ideally started in that first trimester. And the indications for it are really dependent, again, on the woman's personal history, some of it on her family history. So if she has one or more high-risk features, you automatically should be talking about administration of aspirin daily. It's that personal history of preeclampsia, multifetal gestation, chronic hypertension, diabetes type 1 or 2, chronic kidney disease, and then autoimmune diseases, specifically lupus and antiphospholipid syndrome. Moderate risks include nulliparity, obesity, family history of preeclampsia and mother or sister, Black race, low socioeconomic status, maternal age greater than or equal to 35, and then personal history of risk factors such as prolonged period of 10 years between gestations or previous adverse pregnancy outcomes. So now let's move on to the postpartum period. This is where a lot of times women get lost to follow up because unfortunately the baby gets delivered, everything's great, and everyone assumes, okay, the delivery is done, the hard part's over, right? Now she can go home, enjoy her time with her baby. The woman comes back, says my blood pressure is still in the 150s, 160s. We tell her you're stressed, you're not sleeping well, it's okay. Reality is it's not okay, and there's a lot of complications that can come in that initial postpartum period, so I want to talk about those. The first question most women ask is, can I breastfeed? And specifically, can I safely breastfeed on the medications which I have to take for my heart? And in majority of cases, the answer is actually yes. So we all know that ACE and ARBs are contraindicated and you can't use them during pregnancy due to teratogenic effects. However, they have been found to be safe with breastfeeding. Specifically, studies have been done on captopril and enalapril. So those do tend to be our ACE inhibitors of choice if needed for hypertension, again, just because they're well studied. Labetalol, nifedipine, hydralazine, methyl-dopa, our previously discussed medications are also safe. The only things to watch out for really is diuretics, thiazides, and methyl-dopa can decrease the milk supply, and most of it tends to be with the diuretic effect. So as I mentioned, that postpartum gap definitely exists. Systematic meta-review analysis have been done. And again, preterm delivery was associated with twofold increased risk of heart disease, future hypertensive disease, and CAD. Preterm delivery is often a placental syndrome marker, overlapping mechanisms with hypertension and that vascular dysfunction pathway. And again, preeclampsia often worsens after delivery but gets missed. Those women, when they do come in, again, we can't just dismiss them. If they're in that 6 weeks postpartum period, we need to make sure to get an echocardiogram. A lot of times they still require admission, IV antihypertensive medications, and magnesium is still indicated in that postpartum period to prevent seizures if their blood pressure is above 160. So now we're going to shift gears a little bit and talk about one of the more dreaded complications is postpartum or peripartum cardiomyopathy. The definition has changed a little bit over time. In the past, it used to be heart failure during the last month of pregnancy or 5 months postpartum. Now that nomenclature has been replaced with towards the end of pregnancy and early postpartum. The reason is it's very hard to set a heart guideline and say, well, you're 5 weeks and 1 day out. This isn't postpartum cardiomyopathy. But it is systolic heart failure affecting women in that pregnancy and early postpartum period in the absence of other identifiable causes with an ejection fraction below 45%. Risk factors that we have seen in studies is older age, twin pregnancies, multiparity, African American ancestry, genetics, diabetes. Proposed risk factors are smoking, hypertension, malnutrition, and socioeconomic status. I do want to mention with race, there does tend to be a very large prevalence, and unfortunately, we're not sure how much of it is genetic versus socioeconomic status. But if you look at studies that are done in Caucasian women, it's about, 3,000 women, 1 in 3,000, versus if you look in women in Haiti, it's 1 in 300 women develop postpartum cardiomyopathy. So this is just another thing to be very cognizant of. The pathophysiology of it is actually not fully understood, and there's a lot of overlap between peripartum cardiomyopathy and pre-eclampsia, and that's why I thought it's very much worth mentioning both of them and discussing the differences and overlap and things to watch out for when you do see these women. The proposed pathophysiology is a vascular hormonal hypothesis with peripartum hormones plus a cardiac predisposition triggering a vasculopathy and consequently heart failure. Echo remains our test of choice. We're going to assess the ejection fraction, which again is part of the criteria for diagnosis, so can't really go without an echo. But the other important reason to get an echocardiogram is to look for alternative diagnoses. Is there a structural issue? Is there a congenital issue that we missed? Is there a thrombus in the heart? Is there something else that's leading to heart failure before we label it postpartum or peripartum cardiomyopathy? Typically, if we check an NT-proBNP level in preeclampsia, it can be minimally elevated. Normal pregnancy really should stay within the normal range. However, in the postpartum or peripartum cardiomyopathy, most of the studies saw a drastically elevated NT-proBNP in the thousands. Endomyocardial biopsy is typically not indicated unless you strongly suspect an alternative diagnosis, such as giant cell myocarditis or another etiology that requires biopsy. MRI results have been very variable, and there's no specific gadolinium pattern to suggest peripartum cardiomyopathy. With that being said, if you do see late gadolinium enhancement, it's just a predictor of poor outcomes down the line. So as I mentioned, obviously both of these have a lot of overlap and a lot of similarities. But again, preeclampsia, pregnancy-induced hypertension, also presents with pulmonary edema. Then start thinking more heart failure, not just preeclampsia alone. In preeclampsia, you're expected to see a preserved ejection fraction. Again, in postpartum cardiomyopathy, you're expecting that ejection fraction to be below 45%. And then more than 90% of women who have preeclampsia do not go on to develop heart failure. However, at least 50% of women who are diagnosed with peripartum cardiomyopathy did have preeclampsia. So medical management is the mainstay of treatment. However, again, it's going to be very different in pregnancy versus in that postpartum period, because as I said, ACE, ARBs, that's part of our GDMT, our known pathway in heart failure. However, they are teratogenic. Same with spironolactone. So several medications we cannot start until after delivery. Most of the meds do tend to be safe with breastfeeding once the baby has been delivered. One medication that gets brought up at every talk on women's health and pregnancy is bromocriptine, so I thought it's worth mentioning here. It's controversial and considered experimental at this point, at least in North America. It is being used in Europe, but our guidelines as of right now do not recommend it. There's preliminary data to show a benefit from bromocriptine in patients with peripartum cardiomyopathy, but further trials are currently needed to establish the true safety profile of it. There's truly been very few trials. They were small. In South Africa, there was a trial done on 20 women. And then later on, Germany did a trial on 67 women. Again, it's very hard for a new mom to agree to take a medication that we don't know if it's going to benefit her or hurt her. And there's always that ethical debate as well. So most of these trials tend to be pretty small. However, something I'm very excited about is there is a trial called the Rebirth trial, which is randomized evaluation of bromocriptine in myocardial recovery therapy to investigate the effects of bromocriptine on myocardial recovery and clinical outcomes. It's a trial of 200 women with peripartum cardiomyopathy in the United States and Canada. This trial was started in 2022 and has a predicted end date of June of this year. So hopefully this trial should be published, my guess is by the end of the year, maybe next year, and we could have some better data on this drug. Now, advanced therapies, I think we always ask the question, okay, well, what if the heart failure gets worse? What if the heart failure doesn't get better? What do we do? And so again, when we hit a point of cardiogenic shock, where we hit a point where the mother is going to go into cardiac arrest, unfortunately, we do need to focus on the mother's health and getting her stabilized. We try our best to ensure that the fetus can be safe as well, but obviously if the mom is not alive, the fetus isn't going to make it either. So most of the time, we try medical therapy. Inotropes can be given, same as we do in regular heart failure in our sort of standard cardiogenic shock. Mechanical support has been used during pregnancy as well. Most of the time, if we're hitting that crash and burn situation, initiate everything you would in somebody who's non-pregnant as well, call OB and go for delivery as soon as possible. However, there have been a couple published cases of LVAD implantation in women during pregnancy, not just in the postpartum period. Majority of the time, clinicians obviously prefer to do it post-delivery so that we can safely be on anticoagulation, but there are several published case reports of women just going on heparin infusions, avoiding warfarin, getting an LVAD, delivering, and then continuing life with that LVAD. So in terms of labor and delivery decisions, a lot of hospitals are now going for a group approach, talking to maternal fetal medicine, cardiology, OB, and making sure everybody's on the same page, talking about what are the risks currently, what are the potential risks at delivery, and how we're going to approach those. For women who are stable on medications, they can actually deliver vaginally. We don't have to do a C-section. C-section obviously comes with its own risks. So unless it's an emergency, we can treat the delivery the same way, just basically have people on standby and be prepared for potential complications, flash pulmonary edema, need for intubation, and sort of our standard cardiac approach. So a couple other considerations in postpartum cardiomyopathy and just things worth mentioning, again, based on both American and European guidelines, breastfeeding may be considered in stable patients. If you are administering that bromocriptine medication, then breastfeeding is contraindicated. It does work on the brain and dopamine receptors, and it will cross over to the fetus, so we really don't want to change that dopamine and serotonin pathway. And then per AHA guidelines, they basically say emphasize individual decision-making, prioritize maternal cardiac stability, but again, breastfeeding is not contraindicated, and all of these medications are safe and won't cross over. ICD implantation is exactly the same as non-pregnant patients, same indications. And then contraception is something that should be talked about with all patients by really any clinician and every clinician, because I think a lot of times the bigger the team, the more there's an assumption that someone else will have this discussion, right? Well, it's not me, someone else will do this talk. And then the problem becomes that nobody had the conversation, and these women come back 6 months later saying, hey, I'm pregnant again. And so this is something just very important to discuss. It's not that future pregnancies are off the table completely, but it has to be done in a very structured, regimented way. And again, if we are putting them on that GDMT, if we are now giving them ACE inhibitors, we have to make sure they're on some form of birth control so that we avoid that teratogenic effect that it could have on a growing fetus. So typically the recommendation is if their EF has recovered, we try to keep them on GDMT. After 3 to 6 months, if EF has recovered, echo looks stable, we can start weaning them off. And typically, all the studies try to wean off one drug at a time and then repeat the echo and look, has there been a change in their ejection fraction? If you can safely get them off those teratogenic medications, then we can talk about, okay, future pregnancy is much safer. Versus women who don't have ejection fraction recovery, their rates of eclampsia go up by 50% in subsequent pregnancies. And so we just have to make sure to counsel them on this and let them know what their risks are for future complications. So just some takeaways with peripartum cardiomyopathy. Again, we as clinicians need to have a high clinical index of suspicion. Early detection is key because truly getting them on that GDMT is what's going to help with that EF recovery. And then if they do have severe hemodynamic derangements, it should be managed by a specialized team discussing risks and benefits of delivery versus continuing on with the pregnancy. Advanced therapies, again, can also be used in both the peripartum period and postpartum, and then subsequent pregnancies will need very close monitoring. I know this talk is getting kind of long, but I do want to mention menopause just because it's something that's very frequently overlooked, and there was a recent guideline update, so I wanted to make sure everybody's aware. So with age, once we go through menopause as women, estrogen declines. And I found this to be very interesting because I think we've all had those female patients coming in extremely frustrated saying, "Doc, I'm doing everything. I'm a runner. I've been running my whole life. I'm still running 5 days a week. But my cholesterol is out of control. I'm developing diabetes. My husband's making fun of me because he doesn't do any of this and he says he's healthier than me. What am I doing wrong?" Right? Reality is a lot of times it has to do with their hormones, with their genetics, and not with what they're doing. So estrogen typically promotes endothelial nitric oxide production. When women go through menopause, estrogen decreases. Nitric oxide bioavailability decreases, which in turn leads to stiffer arteries, which leads to hypertension. So a lot of times it's a hormone-mediated issue rather than a lifestyle issue. LDL also rises during menopause. LDL shifts towards smaller, more atherogenic particles. Typically, estrogen upregulates hepatic LDL receptor expression. With estrogen deficiency, the LDL clearance decreases, HDL becomes less effective, so LDL is going to accumulate. And I'm not going to read through the guidelines, you guys all know them. I just put it up here because the guidelines don't include menopause as part of the criteria, so we just base it on that same ASCVD risk percentage. But it is something worth keeping in mind. If you're seeing that steady rise of LDL, the woman tells you, "Hey, I'm doing everything the same, I haven't changed anything," do think about the fact that they're at an increased risk of developing Minoca, of developing Inoca, of developing that microvascular plaque that we're not gonna see for several years. And just don't dismiss these patients because that's the big issue. They get dismissed once, twice, 3 times. 4th time, they decide not to come in with the chest pain because they know what the answer is gonna be. And unfortunately, truth is, they do have disease, we just don't see it yet, and it's growing year by year. So the update that happened last year, 2025, at the end of the year, the FDA decided to remove the long-standing black box warning on hormone replacement therapy. So estrogen progestin products were historically linked to heart attacks, clots, dementia, and now they're removing that black box warning saying, hey, you know what, the evidence is actually kind of iffy and it's lower risk when started early with modern formularies. So I wanted to just briefly touch on the indications for HRT because I'm sure in clinic we're going to start seeing more women coming in and asking about it and asking for it, and we need to have a good answer, right? Because as a cardiologist, if you get asked the question, well, I had a heart attack 20 years ago, but I'm going through menopause, I feel terrible, I'm having hot flashes, can I go on hormone replacement therapy? It's very easy to say, I don't know, ask your OB, and then your OB says, well, you had a heart attack, ask your cardiologist. So the reality of it is that hormone replacement therapy is showing to be safe within the first 5 years of menopause, If it's after 5 years, there's still increased risk of clot and CAD development. So the recommendation as of right now, per the guidelines, is to stick within that first 5-year period. There is still increased risk of venous thromboembolism. Again, same as birth control pills, same as pregnancy, same as high estrogen levels. There's still an increased risk of stroke, again, that just comes with that increased thromboembolism risk. And then for women who have hormone receptor positive breast cancer, it also increases slightly the risk of breast cancer. So there are associated risks. However, the benefits for quality of life are drastic, and this is something that still needs to be weighed out for each individual, but at least being able to provide them with these risks and talk them through it, I think is very significant for us as physicians. So just a friendly reminder for everyone, every woman that comes in, ask her pregnancy history, if she's had any complications, and then what age she went through menopause if she's postmenopausal. And then as a system, again, just because we're approaching Women's Health Month, I just wanted to remind us that I think GHI is doing a great job. We have a high-risk cardiac OB clinic. And as I showed you in the beginning, from 2012, when those women heart centers were opened in this country is when we finally saw a reduction in cardiovascular disease death rates in women. So it's just something to keep in mind that if you do have female patients coming in, their chest pain symptoms don't make sense, don't just dismiss them. Send them to somebody who knows about Minoka. Send them to somebody who deals with cardiovascular health in women so that they can walk them through the actual risk factors and get additional studies on them. In that postpartum period, please make sure that patients do have follow-up set up. It's very easy for those things to get lost, and new moms have enough going on without trying to remember if they need to schedule an appointment with someone. So a lot of times they just make the assumption we'll schedule it for them. So I think as a system, we're doing well on that, but just something to keep in mind. And just overall takeaway points, again, we all need to, the better the lifestyle, the better the outcomes, and pregnancy is the same way. But again, if they've had pre-eclampsia, if they've had hypertension, get an echo, look at their ejection fraction, make sure they're on the right meds. If they want to get pregnant again, make sure they're off any teratogenic medications before coming off contraception. And then just remember that pre-eclampsia and peripartum cardiomyopathy have a lot of overlap but are still distinct syndromes. These are my references. And I just want to say a huge thank you to Dr. Taliva for her talk on Inoka and Minoka that she did earlier in the year. And big thank you to Dr. Egelem, our program director, who helped look over my slides and structure my presentation.
Thank you, Dr. Sykalo. If you're viewing online and have a question, I'll remind you to please enter it into the Q&A section, and we'll ask that for you. But in the room, do we have any questions or comments?
Hey, good morning. Thank you for your talk, Christine. One question that I had was, did you come across anything related to cardiomyopathy secondary to pulmonary hypertension in these patients? And if so, how do we go about treating these women, and whether or not these medications like PAH-specific medications would be safe in pregnancy and breastfeeding?
That's a fantastic question. I'll be honest with you, I did not look into pulmonary hypertension. Dr. Eglem, I don't know if you can help out with PAH and pregnancy specifically.
Sure. So as a general rule, if we know a woman has PAH, we generally advise not to become pregnant, right? Because a lot of those PAH meds are teratogenic, and pregnancy, being the stress it is on the heart, would almost certainly precipitate worse than RV failure and almost certain death. Having said that, there's been situations where, a woman has had PH, they're on appropriately managed medical therapy, RV size is normal, echo looks great, and people become pregnant after the fact. And a lot of times, you may be able to keep them on like sildenafil, closely monitor volume status, and then certainly you have high risk OB involved, cardiac anesthesia if they need to, have a C-section and delivery and stuff like that. So, but extremely high risk situation, and not something we would preemptively sort of get into, if that makes sense.
your presentation. I have a question about the peripartum cardiomyopathy and the time frame that it's okay for the women to get pregnant. Let's say their EF recovers and they get better. So between the time their EF recovers and probably you're waiting up to GMT, because I feel like some women want to know, okay, so when is it okay for me to start trying for another baby? And what would be like the ideal time frame? And in the time when their EF is still low, they still have the risk of peripartum cardiomyopathy, what is the advice? Is it like a two-factor family planning method one? Like what would be the general advice during that period?
Thank you. No, that's a fantastic question. So in that initial time period, the recommendation for most women, really regardless of peripartum cardiomyopathy, is at least 12 months to give your body recovery time. If you look, some people say 6 to 12 months. With peripartum cardiomyopathy, the recommendation is at least 12 months for the simple reason of you're going to repeat an echo at that 3 to 6 month mark and see if they've had EF recovery. If they've had EF recovery, they're stable for 6 months, that's when you can start weaning off GDMT. Once you wean off GDMT, you want to ensure that their EF is stable before telling them, hey, it's safe to get pregnant again. If their ejection fraction does not recover, again, the recommendation really is if you can be satisfied with what you have, it's best not to get pregnant again and to stay on GDMT indefinitely. However, if the woman says, you know what, I really want to have another child, we do need to get them off those teratogenic meds first. And then it really becomes an individualized approach, because if your EF is 45, I take you off your Entresto, and then your EF drops to 30, right? I can't safely tell you, go ahead and get pregnant again. I'm going to have to tell you, okay, well, the risk and benefits are such, recommend going back on the ACE inhibitor before trying again. And it would be more of a recommendation at that point to avoid it completely. But it really becomes an individualized approach, and it's how you respond to coming off of those medications.
Could you touch on C-section versus vaginal delivery? I know sometimes when we have these conversations, there's a sense that people feel as though C-sections are safer. We should always, but highlight a bit on what the most common thoughts around that topic at this point.
Yeah, so as of this point, normal vaginal deliveries are actually recommended as long as the mother is stable. So if we've been able to stabilize her on the medications, her blood pressure is within that appropriate range, the recommendation is to proceed with normal vaginal delivery. And again, there's always an OR for a C-section on standby if need be. I think, as Dr. Egelum said, a lot of people just assume C-section's the better route. Fortunately, that's not true, because C-sections do come with their own risk and complications. Things being like administration of anesthesia, how that's going to affect your blood pressure. Whenever you go through a C-section, there's risk of infection, issues with healing, issues with bleeding. If you do have cardiomyopathy and you develop, let's say, an apical thrombus, and now we need to put you on warfarin, but on top of that you had a C-section and now you're constantly bleeding, that becomes another issue. So currently the guidelines actually recommend normal vaginal delivery unless there's issues with the patient being unstable, then to proceed with C-section, more of an emergency. Thank you, everyone.